Good evening, everyone. Thank you for joining us on this webinar tonight, How to Improve Medical Communication with First Nations Patients. I'm Wendy, and I will be your CPSM host for this webinar. You will also hear from Megan. She will be reading questions out this evening. Questions are encouraged. Please submit them at any time throughout the presentation. Our presenters will try and answer them before we move on. And now I will turn it over to our presenters.
Ani Busu. My name is Tara Myran. I'm the program director here for Restorative Practices program here at CPSM. So I am First Nations from Long Plain First Nation and Swan Lake First Nation. It's important for me to identify both because I walk both worlds traditionally. One is Dakota and one is Ojibwe. I'm coming up to my 1-year anniversary on April 16th here working at the college. I feel that sharing these resources today as a person with lived experience is important. I'd like to highlight that I do not speak for all First Nations people, but am speaking from my own life experience and education and hope that it can help to guide you.
Hi, my name is Dr. Courtney Leary. I am the medical consultant with the Restorative Practices program here at the college and also Indigenous health specialist. I am First Nations from Norway House, Manitoba with Norway House Cree Nation. None of you know where that is. That is at the top of Lake Winnipeg. You can check it out. But there will be a map coming up showing all of the First Nations in Manitoba. I grew up in Norway House and have worked there for the last almost 12 years. Before that, worked in Thompson as well as Saugeen and also still work in Broken Head. My practice is almost 100% First Nations patients, and that is how I have tailored it. The pictures there show some of the you can see the community. So one of them is when we did Teddy Bear's Picnic with the other physicians and nurse practitioners at one of the schools. And that is me doing my ADHD clinic outside of one of the other schools in Norway House. And that is myself and one of my good colleagues from Norway House, another physician friend, Dr. Morrow. So just to showcase what it can look like when you get outside your practice walls.
We would like to share that CPSM has developed a land acknowledgement that will be linked in the chat. As a First Nations woman, I will not be sharing a land acknowledgement on treaty land today. However, we will be providing a link for you in the chat. So I encourage you all to read it, reflect, and to acknowledge the land that you live on and the land that you work on. So as we've introduced ourselves, this webinar is focused on how to speak to First Nations patients. Dr. Leary and I will be offering perspectives as First Nation women in this presentation. So the Restorative Practices program here at CPSM addresses anti-Indigenous racism in Manitoba that includes First Nations, Inuit, and Métis people. So here's a picture of our team. We follow under the Quality Department. So Dr. Sonia Brune, Assistant Registrar Quality, myself, Dr. Courtney Leary, Dr. Jason Stoffman, and our coordinator, Megan Cable. Next slide, please. So in June 2025, the Restorative Practices program with CPSM was founded. Our program is the first of its kind in a medical regulatory body. Our aim is to address medical care concerns experienced by Indigenous patients or Indigenous registrants in our province. This work was grounded by guidance from the Indigenous Advisory Circle at CPSM and supports our standard of practice, practicing medicine to eliminate anti-Indigenous racism. Restorative Practices program lives in the Quality Department at CPSM. It's separate from complaints and investigations. The intention of our program is to focus on healing harms in a non-punitive way, to address the root of anti-Indigenous racism when concerns are brought forward, and to heal harms with the restorative justice approach. One of the first things that we did when we came together as a team was to develop a mandate statement. So here's our statement. It is fluid, meaning that we provide this as a foundation, but that it will change as time goes on. We will give you a few moments to read the mandate statement.
Okay, so now we're going to move into the objectives of the webinar. And I guess my first disclaimer is that I don't really believe in objectives. I think that when we go to lectures or we sign up for something and they tell us what they want us to learn, I think that's fair for medical school. But when we are all physicians or we're doing, or maybe if you're allied health or in a different role, I don't think it's fair for someone to tell you, here's what you need to learn, right? Here, I think a better way to put it is, here are the teachings. What you take from it and what you learn is completely up to you. But that being said, we have to have objectives. So by the end of this session, you will expect to learn safer ways to talk about difficult topics, maybe the topics that you may not want to talk about, resources for First Nations patients and how to access them. And the third one would be ways to practice humility in medical conversations.
I'd also wanted to say that we want to acknowledge that we have some guests attending today that are not CPSM registrants. We welcome you and are very grateful that there was so much external interest in this topic.
Oh, we have a question. All right.
What constitutes racism to a First Nation?
All right. So I guess what you should do is look up the definition of racism, right? But if you asked any person, what is the definition of racism? I don't know if we would be able to answer you. Like, I don't know if the general population would be able to answer that question. I can tell you from my own experience, there is a feeling that you get. And maybe Tara, you can also, for me, it's a burning gut feeling when somebody is saying something, when you know that something isn't right, whether how you're being talked to, whether how you're being looked at, whether you're being followed in a store, whether it's, just any interaction. So I don't say there is one definition of this is racist for First Nation people, this is racist for Black people, this is racist for this group of people. I think it's very personal. And even if the person saying the words or doing the action doesn't recognize that this is how it could be perceived, it can still be perceived as racism because it's not what you intended, it's how it was perceived.
So we want to lay the foundation of First Nations and how many there are across Manitoba. So as you can see, there's 63 First Nations in Manitoba. 17 of these First Nations are not accessible by an all-weathered road. The life expectancy of a First Nations person is 11 years lower than the general Manitoba population. First Nations people comprise 12% of Manitoba's population. Therefore, Winnipeg has the highest urban Indigenous population in Canada. We also want to state that Indigenous peoples include First Nations, Inuit, and Métis people, and that there are 5 treaties located in Manitoba. If you do not know what a treaty is, I recommend that you learn about them.
Okay, so we're going to get into some of the safer ways to talk about difficult topics. And again, another disclaimer. I mean, I really hope that after listening to all of this, that a lot of you have learned nothing. I hope that you already know this. I hope that the ways that I'm going to talk to you about communicating are common sense to you and that you're already doing them. They were always common sense to me, but it became very apparent when I entered medical education that the way that I speak to people and the way that I listen was different than how some of my classmates would listen. It was different than what we were being taught formally. So that's the first thing. I hope that you don't actually have to learn anything today. The second thing is that I can only speak from my experience. Like, yes, I'm a First Nations physician. Yes, I'm a First Nations woman, but I am from Northern Manitoba. I'm from Norway House. We are Cree people in Inuit. And so you can't do a blanket statement. That's why I tried to keep the points as general as possible, something that everybody could take in. And this doesn't mean I was taught how to talk to First Nations people by a First Nations physician. These are things that I have used that have worked for me. And they may not work for you, but I think it's always good that we have different tools in our tool belt. So I guess the first thing is I want to say, when one of the topics, like the safer ways to talk about difficult topics, that was sort of a suggestion from a previous not webinar, but one of the feedbacks we got from some of the education courses that you guys are supposed to be doing. And I think people are really interested in that. But when I started to really think about this presentation, I thought, well, who are the topics difficult for? You know, because when I talk to patients, they don't have a hard time talking about difficult topics that maybe we think are difficult. So really, are we making assumptions on someone's willingness to communicate based on our own experiences and our own feelings? Is it because that we have never experienced that before, we've never encountered that before, that we think it would be hard to talk about? So I've never met a patient who wasn't willing to tell their story. So I guess safer ways to talk about difficult topics. The first thing is it difficult for me, the physician, or is it difficult for the patient? Okay. Number one would be, I guess, 1.5, know your audience. So there, as Tara had mentioned, there are many people that fall into the designation of Indigenous. You know, there's First Nation, Inuit, Métis, non-status Indian, Northern, Southern, urban, reserve, isolated. Within religious groups, there's Christian, traditional, there's cultural plus a religion of their choosing, whichever one they decide to subscribe to. And then there's differences between, you could be a First Nations person that was part of the 60s scoop. You could be a First Nations person who is completely removed from your culture, your heritage, your community. You could be a Métis person who has one ancestor 4 generations ago. You could be a Métis person with a status parent, you know? So there is no pan-Indigenous. So it's really important that you try to know your audience. So if you are working in one certain area and you have, let's say 80% of the Indigenous people that you work with are of this type and this background, learn about it, know about it, okay? Get to know who you're working with. So yeah, know your populations, your patients, know the history, know some of the geographical differences. You know, is there a difference between fly-in or road access? You know, northern and southern. How far away from an urban center? You know, how many ambulances do you have in your town? Where's your closest CT? Like, get to know these things about the province. It's really important, especially as a specialist. If you are accepting patients from other areas, it's really good to know your geography. So that would be the first thing, knowing your audience. The other thing I'd like you to think about is explain why you're asking questions. So I have heard this a few times where health practitioners have said, well, I'm afraid to ask about alcohol use, you know, because of that stereotype. I am afraid to ask about, you know, drug use or things like that because they're going to think that I'm racist, or they say that it's racism. Well, it's not, you know, but it's also important that you explain why you ask certain questions. We're having some computer issues, but sorry. The history taking can be complex, and it's good for patients to know why we ask questions. I mean, if you are coming in with chest pain and I ask your cardiac history, that is an obvious question. But if there are questions that you think might not be obvious, maybe to a layperson who's not medically trained, then ask, like, explain with a background, explain what you're trying to know, explain your thought process. It takes 20 seconds, and it can really dissuade some of that miscommunication that can happen between the patient and the care provider. The other thing I'd like you to think about is, why do I want to know this information? You know, make sure that the information you're asking is pertinent. And I'll give you a quick little example. I was working with a student, and they were talking to a patient, and they were asking, you know, like just basic medical information. So it comes out that the patient had recently moved back into the community, had recently been released from, had been incarcerated. And then the learner was asking why, how long, what for, things like that. And I said, well, why? Like, what benefit to the medical, you know, interview did knowing all that information? Because questions without reason is intrusion. You know, it's important that we're not gossiping, that we're actually using this information. So I always stop to think, do I need to know this? And I stop myself. If I'm just curious, then I stop, you know? So I try not to be intrusive. Acknowledging the uncomfortable. So try to ask questions without nervousness. If you are uncomfortable in how you ask a question, then your uncomfortableness, your awkwardness gets translated onto everybody around you. Everybody feels that secondhand cringe that, when you see somebody struggling. So if you are nervous, if you feel awkward, I would say acknowledge it, because you don't want to pass that on to your patients. You don't want to pass it on to, teenagers you're talking to. You don't want to pass it on to family. I think just for better communication. But one thing you might not think about is if you are coming across as nervous and like, I don't know if I want to talk about this, I don't know how to say this, then the person on the other side of it might see that as judgment. Why is this person so nervous to talk about this topic? And if it's seen as judgment, then it might also come across as that they should be feeling shame, especially if it's a story that they already might feel shame for, whether they should or not. And usually not, right? Usually people feel shame that they should not be carrying. So we want to try and normalize these conversations and these topics. So we need to try and make them as comfortable as possible. The last one, or no, not the last one, the second last one, using silence. So this is a trick that I use all the time. And it's because we love to talk, right? Nobody wants to sit there all quiet. It's all awkward. Someone's got to say something. So if you, as the physician, could just shut your mouth for just a little while and just sit and not say anything, it's uncomfortable. And people want to fill the silence, right? And so if you are trying to get information or you're trying to get your patient to open up, this really works for teenagers. The ones who are like, I don't want to be here. My mom made me come, just sit there quietly. Just do your paperwork, whatever it is, somebody will fill the silence. I mean, I think I can think of one time in 15 years that hasn't worked for me. So yeah, use silence to your advantage. Know when to be quiet. But you also have to be listening. You're not daydreaming. Like, yes, you could maybe looking at something else, but when they're ready to talk, you have to be listening as well. So you use that silence to your advantage. Hopefully they'll fill it in. And then the other thing is you don't want to pepper people with questions. So I don't know if you've noticed this, but in my community and how I was raised, if somebody's like, where are you from? Where are you going? What are you doing? Like, it's just like, whoop, that's it. There's no more talking. I'll give you an example. So when I was younger, my mom used to sit and talk to her brothers. And if they knew the kids, first of all, were listening, they start talking in Cree because then we couldn't understand them. But my uncle was telling some juicy story one time, some gossipy story. And I'm sitting there just biting my tongue. I'm like, who is that about? What are you guys talking about? I just wanted to know so bad. And my mom's just sitting there. And then also he tells her some sort of story. And she's like, oh. And she just keeps on doing what she's doing. And I was like, what was that? And then silence, just let it hang, just let it sit there, and then fill it in, right? So it's the because if I had started saying, well, who said that? And what did they do? And where did they go? You pepper those questions at people will clam up. And I have noticed that for my community. So the you got to use it carefully. Now you all know a trick. You have to seem like you're not interested, but it's really giving people space to share in a way that's comfortable for them. Question, go ahead.
Do you have any advice to make mental health conversations, especially those involving suicidal thoughts or attempts in youth, more trauma-informed given high rates of suicide in many Indigenous families? Thank you.
Okay. I'll tell you what I do. This is one of my favorite things. Angsty teenagers in the middle of the night. It's like my bread and butter. I love it. And I just like talking to the teenagers because I find that a lot of them are very open. And the thing I love about kids is that they are a bit more of a blank canvas. Sometimes you feel that people are set in their ways. It's harder to help them. And kids are just begging for help in any way that you can. So I have not been trained specifically with a diploma on the wall for trauma-informed care, but I have lived it. And this is all that I've ever done. So again, sometimes it's silence. And sometimes it's just sitting there and just waiting and waiting and waiting. And in the middle of the night, that can be very difficult. a lot of times for myself, kids will come in and maybe they've been cutting, and the people in their lives are not familiar with this behavior. So to them, it looks like a suicide attempt, and they don't maybe recognize it as a coping mechanism. Not the best coping mechanism, but coping nonetheless. And so I start talking to not only the caregivers and people around them, but also the patient. And so you have to go into what happened today. You know, was there a fight? Was there an issue? Like, try to get down to what was the issue today. And then a really important question I think that you have to ask is, like, we always ask about suicide risk, right? And I think it's really important to ask kids and anybody, do you really want to die? Is that what you want? You know, or are you just so upset, unhappy, distraught, stressed, you just don't know what to do and you wish you weren't here? And those are very different questions, right? Like, there's a difference between I wish I wasn't here in this moment, living this life and having these stresses, versus I want to be dead. And so people think that if we really call it out and say the words, that it plants ideas. But I think it's important to differentiate between those two things, because who amongst us has not had an experience where I wish I wasn't here at this moment? I wish this wasn't happening right now. I wish I didn't have to feel this, you know? And kids, because they can't have that bigger processing of maybe it'll get better or seeing past this immediate crisis, then what they learn is, oh, I wish I was dead. You know, I don't think an 8-year-old understands what death, you know, really, really is. So they know that they pick it up from somewhere. They pick it up from other conversations, from teenagers, from older people, from TV, from wherever it is. Because I don't think they fully can have an understanding of that, the infinity of death, right? So you have to really talk to people. What is it that you're going through right now? And don't sympathize, and don't try and pretend that you know either, if you don't know, you know. And I think we're gonna get into that a little bit. Don't be afraid to use the words, you know. Don't be patronizing. Be patient, and sometimes they might tell you things that you're not ready to hear, but you're not the one living it. So I think that comes up for later on too, and one of my points. I guess the other thing is thinking that you could possibly fix it, you know, that the knight on the horse, and I'm going to come in, I'm going to save the day. And I see a lot of this. I see a lot of this with people who come in from out of town, and there's a teenager who's having a hard time. As like, oh, well, you come live with me, I'll take care of you, I'll make it all better. You know, you have to recognize the history that's behind it. You have to know, we have to empower people. We have to build capacity in people. And this is, I do actually call it forced capacity building. You know, you don't want to enable anybody by trying to feel for them or do things for them. You have to show them that you believe in them, that they can make these changes, that things can get better. But yeah, it's going to be a long road. And yes, it's going to hurt. And yes, it's going to suck. And, you know, but as in whatever capacity that I have, I can help you with this. As a physician, if you are a physician who ever asked the question, there's certain things that you can do, right? Resources. Yeah, certain resources. You know, you need to know when to do with a referral. You need to know when to step back. You need to know, when am I the expert and when am I not? Is there a better person to bring in here? And sometimes it's just a vent, and sometimes it's just a place for someone to feel safe, because usually, you know, I said otherwise, but usually people trust doctors. Sometimes, I guess. Yeah. Was there a follow-up to that?
There is another question.
Yes.
So one of the questions, and I will type it in the chat as well, is we recently had a patient, and following the CPSM guideline for the RX of opioids and benzos, a urine drug screen is needed. However, our patient told us that they feel this is going against their Indigenous culture. How should we navigate this?
That's a tough one, because I don't know what their culture is. Yeah. I can say in my own personal experience, I have never heard that said. I don't know if you've
No.
heard that said, but I can't speak for them because I don't know that. But I mean, I guess there are also programs and there's reasons that we have certain rules, right? So if I'm going to go into somebody else's church, I'm not going to tell them that they should be praying differently. I'm not going to get up there and tell them this is how you need to run this show. I can choose not to go to that church, you know? So I guess with the question, if we're trying to follow our standards of practice and we're trying to follow the guidelines and we're trying to do things as they've been laid out for us to do as physicians, then all we can do is tell patients, in order for me to do my job, here are all the things that I have to do. And whether they choose to participate or not is up to them. Does that sound right to you?
I think
Yeah.
so, yeah. Okay, so now we're going to shift and talk about our resources. But first, we're going to ask you to fill out a poll question. The poll question is, do you currently provide any resources to First Nations patients?
Oh, okay. 50-50. All right.
So, okay, next slide, please. So the next few slides are going to consist of resources that are available to you that will be helpful for First Nations patients. We hope that these will be additions to your toolkit. So the first resource we're sharing is the Non-Insured Health Benefits Program. This makes a significant difference when doctors prioritize referrals for First Nations because it removes financial barriers to accessing care, such as specialists, covering travel costs for appointments, and to set up direct billing to avoid upfront payments. So currently, Southern Chiefs Organization employs non-insured health benefits navigators who are available for community members who may have difficulty accessing their non-insured health benefits.
We hope that most of you know the legacy of Jordan River Anderson and Jordan's principal. Jordan was a First Nations boy from Norrie House Cree Nation here in Manitoba. Born with complex medical needs, he spent more than 2 years unnecessarily in hospital due to the province of Manitoba and the federal government arguing over who should pay for his care at home. Jordan never made it home and passed away in hospital at the age of 5. Jordan was never able to spend a day in his family home. His life and journey inspired the creation of Jordan's Principle, ensuring that First Nations children receive the health care and support they need without delay. Taking time to complete a referral letter to Jordan's Principle for a First Nations child can help them beyond measure. Your referral can help with access for medical equipment, mental health services, speech therapy, and many other life-promoting and saving services. In the YouTube link that will be shared in the chat is a message from Dr. Cindy Blackstock, where she shares about how to submit a request to Jordan's Principle. Understanding the process may help you and the care you provide. It's important to remember, as with any other government program, sometimes they are not easy to navigate. And funding changes, the people that work there change, so there may not be a one-stop shop for people to get information on Jordan's Principle. I would encourage you that if you happen to work with First Nations children, that you find out who would be the contact person. So myself in Norrie House, I have a contact person in Norrie House that works for Jordan's Principle. Depending on where you work, find out who those contact people are, find out who the regional manager would be, and how to navigate that program for the kids in your practice and in your care. A little bit of work now will save you a lot of time later and will make a huge impact on your patient's life. Question.
What are some practical communication approaches we can use when an Indigenous patient seems hesitant or quiet during the consultation that we can build trust without making them feel pressured?
Be quiet. No, I think the silence, right? You don't pepper questions. I mean, and we're taught to do that. Why are you here today? How long has it been happening for? Tell me about your symptoms. What makes it worse? What makes it better? We are taught to do this. So sitting quietly and inviting them to talk is, I think, one of the better ways. And the very first time that I ever went to job shadow was Dr. LaValle. And I went to the Aboriginal Health and Wellness Center, and I sat there, and he let me shadow with him. This is before I got into med school. And I could picture it, because he would sit there and he would talk to his patients, and what I could picture was him sitting across from his patient at a kitchen table with a cup of tea. That was the feeling it gave me when I watched him talk to people. And so if you can imagine that, imagine that this is more of a conversation and let them let it flow. Like, we are taught to follow the guidelines. You ask this question, then you ask about surgeries, then you ask about allergies, then you ask about hospitalizations. That's not how people talk usually. Let the conversation flow. And it is our job to, take the pieces of that Jackson Pollock painting and turn it into something more like a Picasso that you can maybe see the shape of. Okay? So don't cut people off. Try not to interrupt. Write down questions as they come up in your mind. It's okay to be quiet, and it's okay to also be like, oh, and they'll fill the space. They will tell you more. Yeah. Okay. Okay. So for First Nations patients at the Health Science Center, there is an Indigenous health team that can assist with navigating care. At the link in the chat, there are also Indigenous health services available in other health authorities throughout Manitoba. So you can check out those links. Go to the next slide.
Yeah. So I encourage you to review the resources shared today, or to delegate someone to review them in your area in order for you to build those relationships and to become more comfortable with knowing when to make referrals and connections for further support. So this one is a resource for your toolkit. It's 24/7 counseling and crisis support. It is available to First Nations 24 hours a day, 7 days a week through the Hope for Wellness hotline. And having more tools available to you and in your toolkit having more tools available to you in your toolkit leads to better care for First Nations patients and helps to build trust, leading to better outcomes.
All right, so we're into ways to practice humility in medical conversations. So first things first, basic definitions of what is humility. So I want you guys to just quickly read over these. These are like Google definitions, okay? And then I want you, as you're reading that, I want you to think, what is it to you? Because when I have to define humility, I mean, it's probably very different to me than what it is to other people. And so depending on your definition, how could I possibly tell you how to practice it? So these are the definitions, but I want you always to keep in the back of your mind, what does being humble mean to you? So we're going to move on. I don't see the point. When is it? There you go. Okay, first things first, accept that you don't have the right to know everything. And this is kind of like we talked about giving your patients time to trust you. So patients may be protecting themselves from a system by not sharing all the information. They're not trying to be deceitful. They're not trying to, get around you. They just might not trust you yet. And maybe it's not safe to share. I'll give you an example. So somebody might be struggling with mental health or stresses in their life, and they happen to be pregnant. And as a First Nations woman, you're going to get up and you're going to shower that morning, and you're going to put on your nice earrings, and you're going to dress nicely, and you're going to do your makeup, and you are going to look your best to go for your OBGYN appointment. Because if you show up, messy bun, yoga pants, maybe some coffee spilt on you from the drive over, and you're not absolutely 100%, then sometimes the perceptions can be, what's happening at home? Is this person okay? Is that baby going to be okay? Do I need to call CFS? These are real fears that live inside of us. So your patient, unless they know that they can trust you with information, might not share things with you. And that's just them protecting themselves. Their experiences with systems may be different than yours, and you might not understand them, and you might not believe them. So, but when they trust you, they'll tell you. The other part is asking questions that you are not prepared for the answer for. If you ask a patient questions about their life, their home life, tell me about what you've been through, or tell me about your childhood or your history, because you think that it pertains, unless you are ready to hear the answers to those questions, don't go opening cans of worms if you don't have the time or the skill to be picking up worms, okay? Just don't. that is when you act as, you know, a manager, and you hand it off to somebody who can handle it. An example of that would be, and these are like all the examples I give you, these are real stories, but I'm just obviously not going to tell you who they are. Somebody has gone to see a counselor, you know, a mental health counselor, and tells them the story of what they're going through, what their family's going through at that time. And the counselor is like, wow, I've never heard anything like that before. And then they just can't do their job. So they asked all the questions, and then could do nothing to help. And all they did was open up wounds and leave that person walking out of that office frustrated and like, why the heck did I even bother? You know, you can't help me. So we protect our stories and our information very, very, very closely. The second thing would be accept that you don't have an answer for everything. You know, like I just said, you might not be able to process all of this information. And it's okay to not to have an answer. And it's okay to tell people that you don't have an answer. Even if it's a medical issue, it's okay to say, actually, I forgot about that. I'm going to go look up, you know, like that's okay too. We don't have to know everything. And medical school does not teach you how to deal with every social situation either. You know, we end up being counselors, but that's not what we're trained for. But people come to doctors for just about everything. So, you know, it's okay to say, I'm not sure. I don't know. If you want to validate your patient's experiences and what they're telling you, you can use it, you know, you have to have some phrases that you can turn to. Because if you're feeling a little bit of shock and you're trying not to come across as projecting shame or judgment, you need to have some tools in the tool belt that you can pull on when you're not really too sure what to say. So one could be like, I can only begin to think of how I would have responded to that. Or I don't know what I would have done if I was in that situation. I don't know what I would have said, or, you know, if that was put upon me. And that's important too. It's not that people go out looking to have their life traumatized, you know. It's things that are put upon them that they had no choice. So if you ask those questions, the next thing would be, how are you handling that? Is there a way that I can support you? And if you're trying to bring this into the doctor-patient relationship, then you can ask, you know, what were you hoping that I could do for you? Sometimes people just need to talk, and they just want to tell somebody that they maybe trust about this story. And it may have an impact on their healthcare, or it may not. You know, they might be looking for something very specific. Actually, I wanted you to sign this letter for me as I access this service. Or actually, I'm really worried about this, you know, like find out what it is that your patient is wanting from you. You may or may not be able to do it, but at least they told you, and you can set realistic expectations. And another thing to do would be to tell your patients, that would be like, try to relate if you can in the tiniest way. That would be really hard for me to share. Thank you for sharing that, you know, or thank you for trusting me. Thank you for allowing me to be a part of this story. And it's just acknowledging the fact that that might have been something difficult to share, that maybe you didn't know how to handle it, and you wouldn't, because you guys have different resources and different life experiences. And then if you're completely blown away, you know, then you can also say, wow, I don't even know what to say, you know. And sometimes having, like when you have a friend and you tell them a story and they're just like, God, you know, I don't want to swear. Tara told me not to swear. But, you know, having somebody to sit with you in that moment in disbelief is better than sitting there by yourself. Okay? Yeah. I think, we'll just move on. So third one, admit your limitations. Know what you don't know and learn to ask questions from the right people. Our patients can be great teachers, but it's also not their job to educate us on all of their obstacles and struggles. We can learn about the history of First Nations people. We can go to the communities, we can read, we can research, we can watch the movies. I recommend Conspiracy of Silence and Indian Horse. But also remember that what somebody has learned in a book is nothing compared to what you've learned in life. So if you do some research and you read some essays, or you go read this book, and then you come back, oh, I know all about you now. Like, I went to one of your celebrations this summer, so now I know everything about being Ojibwe. No, you don't, you know? So always keep that in mind too. Like, keep your humility. Like, learn and know that you can always learn, okay? Number 4, I think, yeah, there's something I want to add at the very end. So honoring your patient. I like to remind patients of how far they've come. I like to tell them that I'm proud of them. I especially like to tell the young kids that I'm proud of them, you know, and it means a lot. You know, how well they're doing, you know, even if it's like, oh my goodness, your A1C is down, you know, 0.5%. Amazing. Good job. You ate a vegetable today? Good job. You know, I ate a vegetable today. Good job, Courtney. You know, so tell them that you're proud of them. Tell them that you appreciate them sharing. And even if they're struggling, because often people just see their deficiencies, right? We focus on the negatives and like, oh, I smoked yesterday. And it's like, yeah, but you didn't smoke today. Good job. You know, like we have to focus on the positive things. And it's okay to honor your patients, to tell them how proud you are of them. It means a lot. Think about what it meant to you when your parents would say it to you. You know, think about what it would mean to you if a doctor ever told you, I'm proud of you. Like, holy smokes, you know, that hits hard.
Okay, next slide.
There was one thing I was going to add. Oh, right. Hold on. Questions next. One of the things, like when we're talking about, you know, difficult topics and somebody tells us something, you have to be very careful that when a patient shares something with you, and if you are maybe not quite ready to receive or process that information, if you become upset, the patient then turns around and starts making you feel better, you know? Oh, that's okay, it's all right. So the patient now is consoling you. And so the person who has experienced the trauma is actually trying to make everyone else around them feel comfortable by minimizing their emotions and their feelings. That's not okay. Always remember, the fountain pours out. You know, if there is a death in the family, you know, the parent, let's say it was a child, the parent is the one, right, in the center. So the teacher doesn't get to go crying to the parent, oh, I'm going to miss them so much in this, you know, no. The fountain pours out, okay? So if you are more removed from this trauma or from the incident or from the story, you don't get to complain about how hard this was for you to hear or how hard, you know, how anything, like your emotional response to that. Be there in that space with them, but don't try and also own it and feel it. Don't make your patients make you feel better. That was what I was going to say. Okay. Sorry, give a little lecture there. As per usual. Question?
The question is, doesn't "I'm proud of you" from a middle-aged white lady come across as condescending?
I guess I've never thought about that because I'm not a middle-aged white lady. But I mean, I would be happy just for someone to say, you know, I'm proud of you. So let's unpack that. I was once told, I was once compared in Thompson by our chief medical officer to the homeless population in Thompson. And what they told me was, you must be so proud of yourself for being able to go to med school, because I see what the Native people are like around here, and you were able to finish. And I was like, did you just compare me to, like, what are you doing? So yeah, like that you must be so proud of yourself, and then having the comparison or putting a negative with it, you know, that's different than like, you got an A in your test, I'm so proud of you. Like, how would you, if there's going to be a little attachment at the end of it, then I would say, yeah, that might come across as condescending. But I would say, if it's something that you would say to anybody in your life, then probably not. So I guess maybe just be careful how it comes across, like, and how you're going to say it. But I don't know. I don't see that as a problem. If it's like, oh, you must be so proud of yourself. I'm so proud of you that you survived this, you know, because I see all the other Indigenous people not surviving. Now that's condescending, you know. But if you're just making a statement because you are actually proud of them, you know, like I tell people that I'm proud of them when their A1Cs come down or when their blood pressure is controlled, you know. I don't consider that condescending. But what do you think?
I think, yeah, no, I agree with what you have to say. I personally, I would feel more better leaving the doctor's room knowing that I have somebody there to support me. It may not be proud of you, but I've noticed that you've come this far from where you were before. Maybe just thinking about the way that you would say it, but making sure that your patient feels comfortable, safe, and knowing that when they go home, they're going to share that with their family that, you know what, I went and seen a doctor and it went really good today. I feel safe. I feel comfortable. And that opens up doors for everybody else, because then they turn around and say, you know what, I think I'm actually going to go to the doctor. Because like right now, many of our people, Indigenous people, are diagnosed as stages 3, stages 4, which is unfortunate, right? So we want to try and break that barrier and get them diagnosed as levels 1, levels 2.
Yeah.
Okay. So next slide. So here is how you can contact our program. If you witness an incident where a physician or other registrant is racist towards an Indigenous patient, please contact us. Or if an Indigenous physician or registrant experiences racism, please connect with us. You can always self-refer or refer on behalf of someone else. We want to address the feeling of racism that First Nations patients are too often left with when accessing medical care. Your feelings matter, and we want to hear from you to support change and healing. Thank you, Miigwech.
Did we have any other questions?
Yes, we do
Okay.
have one more question. We had some comments throughout as well. But the question is, and I'll put it in the chat, how to manage breaking their trust when a child is about to tell you about abuse that you have to report.
So for older kids, I always tell them that there are some things that I have to report, just legally I have to report. And I do also acknowledge that maybe that will dissuade you from telling me everything, but the goal is to try and keep you safe. And then also to try and keep other people safe, as we know there are, some things that we have to report. For a younger child, I don't know if I would consider that breaking trust. I think that if a child is brave enough to tell you something, then they want someone to know, because there are so many that don't say anything.
They don't want to trust in their family.
They hide it. They don't talk about it. This is, they could hold on to it their entire life. And I think even just like I said, for the teenager, if you're telling the patient that what you have told me is very concerning, and I need to make sure that you are as safe and as healthy as possible. And my job is to bring in other people that are going to make sure that you're safe and that you're healthy. And I want you to know you've done nothing wrong. And I'm so glad that you told me. And we will be here, help you, support you. I'll introduce you, do the referrals, do all the things that you need to do. But I don't think that a young child would look at that as breaking trust. Usually when children are being abused, it's usually by an adult. So I think their perceptions of trust would already be a bit off. Yeah. But I think the most important thing is that you have to tell the patient that you're doing what's best for them. As far as you are aware, as far as our laws, and what we have to do, you have to tell them, as a doctor, this is what I have to do. As a doctor, I have to tell somebody when I think, somebody might be in danger or somebody might be being hurt. And I really just want to keep you safe as best as I can. And hopefully they'll understand that. Yeah. But I think the fact, if this is the road we're going down in terms of, if the child has been abused or is being abused and you are about to open all of that up and involve the authorities, I think you might be a very teeny tiny part in their story. And them remembering after they go through the investigations and after they go through the therapy and after they go through 20, 30 years of however long it takes to release some of that, they might not even remember you at all. So be careful that we're not maybe putting too much importance on yourself. So I'm going to jump in and just say that I do want you guys to remember, as we said in the beginning,
Yes.
our experiences are our experiences, you know, and I would encourage everybody, if you have questions about Indigenous culture, language, history, all of that, do your research, do your readings, but reach out to your local experts. So reach out to the people that you work with and ask them if they'd be willing to help guide you in this. If you have questions about communication, you know, I can't teach everybody everything. I can only teach from what I've learned in my life. And that's not going to work for everybody. So yeah, we speak from our own lives and our own experiences, but that doesn't speak for everybody. So don't be afraid to go out there and source some of your own experts.
Great. Well, with that, that concludes our webinar this evening. So thank you for joining us. See you next time.